Welcome back for another deep dive. Today we're going to be tackling ICD-10-CM coding for sepsis.
Oh boy.
Yeah,
Buckle up.
we're going to be going deep.
It's a big one.
And to help us navigate this, we'll be using some guidelines from the Absolute Medical Coding Institute, and that includes their MCG manual. You can find a link to that down in the description.
Oh, that MCG manual. Yeah, it's a good one.
It is.
It's very helpful.
So sepsis coding is, I'm sure many of our listeners know, is a very important topic. It's also very, very complex.
Absolutely. And it's one of those things, where accurate coding, it really has like a ripple effect throughout the healthcare system.
Right. It's not just...
So it's not just about getting the code right. It's about making sure that, the data that's being collected is accurate, and that has implications for everything, resource allocation, research, all sorts of things.
Yeah, and I always get a little tripped up on the different levels.
Yeah.
We've got sepsis, severe sepsis, and septic shock. Can you maybe just walk us through that hierarchy?
Yeah. So think of it as a spectrum of severity. You've got sepsis, which is like the initial stage. It's like the foundation of a house.
Okay.
Then you've got severe sepsis, where organ dysfunction sets in. So now we're adding walls to the house.
Right.
And then finally septic shock. That's the most critical stage. That's where things really start to crumble. It's like the roof caving in on the house.
All right, I like that analogy.
Yeah.
So when it comes to actually coding this, how do we distinguish between sepsis and severe sepsis? Like, what's the key differentiator there?
Yeah, the key really is that documentation of organ dysfunction.
No.
So with sepsis, you're going to have a single code for the underlying infection. With severe sepsis, you're going to have two codes. So you'll have the code for the infection, and then you'll have R65.2, which represents that severe sepsis. And the provider documentation really needs to clearly show that organ dysfunction is directly related to that infection.
So if a doctor's notes say, the patient has, this infection, but then they also mention kidney failure, for example, that's a sign of organ dysfunction. So that would bump it up to severe sepsis.
Exactly. So that documentation is critical. It really paints a clearer picture of what the patient's dealing with.
All right. Now, what about septic shock? Where does that fit in?
So septic shock basically means that on top of severe sepsis, the patient is now experiencing circulatory failure.
Oh, wow.
So their body is really struggling to maintain blood flow. It's a life-threatening situation.
That's when things get really serious.
Yeah.
Are there specific codes for septic shock?
Absolutely. So you would use R65.21, and that represents severe sepsis with septic shock.
Right.
So that code's telling us that both conditions are present.
So that's a combo code.
It is.
It's a 2-for-1.
Exactly. Now there's another code for septic shock, and that's T81.U2. And this one is used specifically for cases where the septic shock develops after a procedure.
Oh, so there's different types of septic shock.
There are.
And the coding changes based on, where it came from.
Right, because we need to paint an accurate picture of what happened with this patient. So if their septic shock is linked to a procedure, we want to make sure that relationship is reflected in the coding.
Okay, this is already getting pretty complex, and I imagine sequencing these codes correctly is super important.
Oh, absolutely. Sequencing is like creating a timeline of the patient's condition.
Right.
And this is where you got to remember that golden rule. The code for that underlying systemic infection always comes first.
So if it's sepsis stemming from pneumonia, we code the pneumonia and then the sepsis.
Exactly. You're establishing that the pneumonia is like the root cause.
Gotcha.
And just as a little side note, if for whatever reason the documentation doesn't tell you what organism is causing the infection, there's a default code you can use, A41.9, for sepsis from an unspecified organism.
Okay, so it's like a placeholder until you get more information.
Exactly. Now, what happens if the infection isn't present on admission? What if it develops later during the hospital stay?
Oh, that's a good point.
Yeah, so let's say a patient is admitted for something totally unrelated, and then during their stay, bam, they develop severe sepsis.
Oh.
In that case, both the infection code and the severe sepsis code, R65.2, would become secondary diagnoses.
Okay, so it's like saying, hey, this wasn't the initial problem, but it became a big problem during the hospitalization.
Exactly. It's all about capturing that timeline.
All right, so we've got different types of sepsis. We've got the timing of when it develops during admission. Now, I know things can get even trickier when we start talking about localized infections.
Oh, yeah.
I'm already trying to wrap my head around all this. How do localized infections add another layer of complexity?
Okay, so let's imagine a patient is admitted for sepsis that's caused by a UTI.
Okay.
Now, that UTI, that's a localized infection, right? It's specific to the urinary tract, but it has triggered a systemic response leading to sepsis.
So even though the infection is just in that one spot, it's still affecting the whole body.
Exactly. And so in these cases, the sequencing gets even more specific. We're going to code the systemic infection first, then the localized infection, and then finally R65.2 if severe sepsis is also present.
So it's like a hierarchy of codes.
It
It
is.
shows the progression from
Exactly.
the systemic to the local to the severe.
You got it.
Okay, wow, this is a lot to take in.
It is.
I'm starting to see why accurate sepsis coding is such a challenge.
It's like a puzzle.
Yeah, it's like a medical puzzle with all these different pieces and rules. And speaking of important pieces,
Yes.
provider queries.
Oh, the all-important conversation between the coder and the doctor.
Yes, because sometimes the documentation might be unclear.
Absolutely.
For example, I was looking at a chart earlier and it said urosepsis.
Ah, yes, urosepsis.
So that sounds like it should be sepsis related to the urinary tract.
You would think so, but here's the thing. Urosepsis is a non-specific term.
Oh, really?
It doesn't automatically mean sepsis.
What?
It could be a localized UTI or it could be something else entirely.
So we can't just assume and code it as sepsis.
Absolutely not. That's where a query to the provider is so important. You need that clarification. Is it truly a systemic infection meeting the criteria for sepsis, or is it something else?
Okay, that makes sense.
Yeah.
You can't just code based on assumptions.
Yeah.
Are there any other red flags when you're looking at documentation that should trigger a provider query?
Definitely. Remember how we were talking about acute organ dysfunction being a hallmark of severe sepsis?
Yeah.
Well, sometimes the documentation might mention organ dysfunction, but it's not clear if it's directly related to the sepsis or not.
So like if it mentions that the patient has kidney problems, but we don't know if it's because of the sepsis or because of something else.
Exactly. And in those cases, you want to query the provider to confirm that connection. That confirmation is what justifies using that R65.2 code for severe sepsis.
Wow. So these provider queries really are our lifeline.
They are.
When the documentation is unclear, it helps us fill in those gaps and make sure we're coding things accurately.
It's teamwork. You know, you're like a detective piecing together the puzzle of the patient's condition, and sometimes you need to consult with the expert witness, the doctor, to get the full story.
I love that. It really emphasizes the importance of collaboration between the coder and the provider.
Absolutely. It's a team effort to ensure those medical records are accurate and complete.
All right, now before we jump into the wild world of post-procedural sepsis, why don't we take a quick breather and just recap what we've learned so far about sepsis coding?
Okay, sounds good. Okay, so we've talked about, the different levels of sepsis. We've talked about the importance of that underlying systemic infection, and of course, those provider queries.
Yeah, those are key. When the documentation is unclear, those queries can really save the day.
Absolutely. So now are you ready to dive into the world of post-procedural sepsis?
Oh, yeah. Let's do it. I'm feeling like a coding detective ready to solve some medical mysteries.
All right. So let's say a patient undergoes surgery.
Okay.
And then a few days later, they develop signs of sepsis.
Oh, that's not good.
Not good at all. And especially when it comes to coding, we need to see clear documentation linking that infection directly to the procedure.
So the doctor's notes need to explicitly say, this infection is a result of the surgery.
Exactly. We can't just assume that connection. So once we have that confirmation, then we can move on to the specific codes for post-procedural sepsis. And those are going to be different from the general sepsis codes we talked about earlier.
Right. And this is where those sequencing rules come back into play.
You got it. So for post-procedural sepsis, we're going to start by coding the specific site of that post-procedural infection.
Okay.
So that could be the surgical wound.
Okay.
Could be a UTI following a catheterization.
Right.
Could be any site related to the procedure.
So if the injection started in the surgical wound, we would use a code specific to post-surgical wound infections.
Precisely. And those codes are usually going to fall somewhere within that T81.41, T81.43 range.
Okay.
Once we've got that infection site, then we code for the post-procedural sepsis itself.
And that's where we would use codes like T81.44 or O86.04 for postpartum sepsis.
You got it. And if that post-procedural sepsis progresses to septic shock, guess what?
I have a feeling I know.
We've got a code for that too.
Is it T81.102?
It is. T81.112, that's the one specifically for post-procedural septic shock.
So it seems like whenever we're dealing with post-procedural complications, those procedure-related codes always come first in the sequence.
That's a great observation. It's all about that cause and effect.
Wow.
The procedure happened, and as a result, this infection developed.
Yeah, it's like we're telling a story.
We are.
With the codes. It's like a narrative of the patient's experience.
Exactly. It's all about telling that story accurately and completely.
This conversation has really highlighted the importance of specificity in medical coding.
Hmm.
It's not just, picking a code that's close enough. It's about finding the code that really captures all those nuances.
Oh, I completely agree. Each code is telling a story.
Right.
And we need to make sure we're choosing the right one to reflect the patient's unique journey.
Well, speaking of unique journeys earlier, you mentioned something that kind of blew my mind a little bit. You were talking about sepsis that's not actually caused by an infection.
Right. So in some cases, you might see the body having that same inflammatory response that you see with sepsis, but it's actually triggered by something that's not an infection.
Wow. So like what could trigger that?
So it could be trauma, it could be burns, even pancreatitis.
So the body's reacting in a similar way, but the root cause isn't an infection.
Exactly.
How do we code that?
So in those cases, we kind of have to deviate from the typical sepsis coding sequence. Since there's no infection involved, we're going to code that non-infectious condition first, as long as it's the principal diagnosis.
So if a patient is admitted for a severe burn, and then that burn triggers this kind of sepsis-like response, we would code the burn first.
That's right. And then we would follow that with codes for any other related conditions.
Okay.
Like organ dysfunction, if that's present.
Would we use R65.1 in that case for SIRS?
So R65.1, that's specifically for SIRS that doesn't involve organ dysfunction.
Okay. And here we're really talking about situations where the non-infectious condition is causing a response that's much closer to sepsis and often involves organ dysfunction.
So even though it's not technically sepsis because there's no infection, we're still coding it in a way that captures how serious it is.
Exactly. We want to accurately represent the patient's condition.
This is fascinating. There's so much more to sepsis coding than I realized.
There's a whole world.
Yeah, it's not just about knowing the codes, it's about understanding the conditions and the sequencing rules and when to query, and
Absolutely.
it's a lot.
But it's an important part of healthcare.
Now, before we wrap up, I do want to touch on one more scenario. Hemolytic uremic syndrome associated with sepsis.
Oh, yes, HUS.
Yeah.
So that's a serious condition that can lead to kidney failure.
Right.
And in some cases, it can be linked to a preceding infection.
So if it's linked to sepsis, how does that affect our coding?
So if a patient is admitted because of HUS that's linked to sepsis,
Mm-hmm.
we have a specific code for that, D59.31 for infection-associated hemolytic uremic syndrome. And that becomes the principal diagnosis because that's the main reason for the admission.
Exactly. And then we follow that with the codes for the systemic infection and any other related conditions like severe sepsis.
So here, again, the fact that it's linked to sepsis completely changes the coding sequence.
It does. And it really just highlights how complex medical coding can be.
It is.
We're not just dealing with isolated conditions. We're dealing with how all these different conditions can interact and impact a patient's overall health.
This deep dive into sepsis coding has been so insightful.
Good. I'm glad.
It's amazing how much goes into accurately capturing these conditions in the medical record.
Well, and it really just goes to show the importance of medical coders.
Absolutely.
They're the ones behind the scenes making sure that the data is accurate, and that ultimately leads to better patient care and better research.
And let's not forget the AMCI MCG manual.
Yeah,
That has been our guide through all of this.
absolutely.
You can find a link to that in the episode description.
Definitely check it out. It's a must-have for any coder who's dealing with sepsis.
Okay, so before we officially conclude, I do want to touch on one last thing that I think kind of brings everything together. Okay, so we've talked a lot about the technical side of things, the codes and the sequencing and the queries, but I want to take a step back and look at the bigger picture here. What's the real-world impact of all this? Like, why does accurate sepsis coding really matter?
That's a great question because it's easy to get caught up in the details of it all, but we can't lose sight of why we're doing this. And ultimately, it all comes down to patient care.
Right, because it's not just about getting the numbers right in the chart. It's about helping patients.
Exactly. Accurate sepsis coding helps us track trends and identify areas where we can improve and develop better strategies for, prevention and treatment. It all starts with the data.
So it's like each case of sepsis that we code accurately, it's like adding a piece to a giant puzzle.
That's a great way to think about it.
And as we get more pieces, we start to see that bigger picture. Like, are there certain demographics that are more affected by sepsis? Are there certain procedures that have a higher risk of post-procedural sepsis?
Exactly. And those are the questions that researchers and healthcare providers need to be able to answer.
And they need good data to do that.
They do.
Yeah.
And that data starts with us with accurate coding.
Wow. So it's like a chain reaction.
It is.
Like our work as coders, it can actually lead to real changes in how we approach sepsis.
Absolutely. For example, a hospital might use that sepsis data to implement an early warning system to identify patients who are at risk so they can intervene faster and hopefully improve outcomes.
That's amazing.
Or researchers could use that data to develop new treatments or preventive measures. So you see accurate coding, that's the first step.
Wow, I never really thought about it that way. Like, my work as a coder can actually help save lives.
It absolutely can. And that's what makes this profession so rewarding. You're playing a vital role in the healthcare system.
I want to leave our listeners with a question to think about. How can understanding sepsis coding help you advocate for better care?
That's a great question. It challenges us to think beyond just the codes themselves and see how our work can make a real difference. Because we're not just coders, we're advocates for accurate data, and ultimately we're advocates for better healthcare for everyone.
That's a great point. And remember, everyone, the learning doesn't stop here. The MCG manual is a fantastic resource, so definitely check that out. The link is in the episode description.
Absolutely. Keep learning, keep asking questions. This field is always changing.
All right, well, it's been a pleasure diving deep into the world of sepsis coding with you.
Likewise.
For all of our listeners out there, keep those coding skills sharp and remember the impacts that you're making. And we'll see you next time for another deep dive.